We'll look at it through another view. So this is looking from the top, this is the front, this is the back. And you see, come here, there's this thing, this big white thing that lights up. It's a ganglion, or a perilabral ganglion, okay, or cyst. So why, it's not painful. Why is it painful? Because we know our anatomy. The suprascapular nerve here supplies supraspinatus. We know supraspinatus is powerful. Infraspinatus gets messages from that nerve once it bends around this corner. It's like the root of acromion. So the nerve bends around the corner like this, and that's where the cyst is. That cyst is squashing it. So the cyst is making the nerve stop working. So that's not painful in itself. If the nerve stopped working, he's got an unbalanced shoulder because subscapularis supraspinatus is now pulling his humeral head anteriorly. Okay? So if you send him to somebody and they put an injection in his shoulder in his subacromial space, his symptoms will get better for a little bit. You do a subacromial decompression, his symptoms will get better for a little bit. You're not getting rid of the problem. So you need to decompress the cyst and repair. And the reason why that cyst appears is there's a little rent in the labrum where it just keeps pushing fluid through. You get the same thing in the knee, perilabral cyst on the lateral meniscus border, and it just pumps out. It's like a one-way valve. Okay, so you do an operation where you go into the shoulder and you aspirate. I'm not going to go through the operation, but you go into the shoulder. There's a little tear in the labrum. You put a little knife in there. You pop it. It goes whoosh, and then you repair the labrum. That's the end of it. Problem solved. Depending on how long the cyst has been there, the muscle will recover and their impingement will go. Not much like this guy. Okay. Interesting from an examination point of view, perhaps.
So you can get that sort of differential diagnosis just from your examination with the wasting infraspinatus. It's not the only place you can get perilabral cysts though, so if you get it even more proximal, you can get wasting of both supraspinati, and that could be because of a tear, or it could be because of a cyst, so you still need to investigate.
So which is why scans are confirming or refuting really rare things, basically. So your examination, all you're doing is refining what we're finding. So, next person, perhaps a bit more straightforward, 36-year-old, fit and well chap, left shoulder pain, he's had it for 5 months, insidious onset. It started one morning, okay, when he was thinking, what the hell was I doing the day before? I can't remember. Hurting my shoulder, was on the tube, I was holding the bar, I can't really remember anything particular, but through that morning his shoulder pain got worse to the point that evening, he got home from work, terrible pain, he didn't sleep that night, and it was just sort of persisted for a few nights. He didn't sleep, he's taking painkillers, it wasn't great. And then his pain is, we're now week 2, his pain's got a bit better. By the time he's come to see you guys, his pain is better, but his shoulder, he can't do what he wants with it, okay? So, differential diagnosis.
Acute ulcerative bursitis.
Yeah, that's definitely high on the list.
Frozen shoulder.
Or frozen shoulder, that's high on the list as well, equally high on the list. If he said, so they're my 2 top diagnoses as well. If he said, I've got pain going down my arm and I've got a bit of pins and needles, and it's sort of like, sorry? Yeah, so cervical radiculopathy, or he could have a viral breakalgia. There's something called Parsonage Turner that will present usually in the morning, actually, which is why I'm saying it. Same history as cervical radiculopathy, MRI of neck normal, okay? And it's because of a viral infection involved. Again, you will see these people, I promise you, okay? So, what we're going to do, we are going to examine them, yeah? Examine them. So this is him, all right? On one side, he can do this, which is the normal side. The other side, he can go to here. He's got 0 external rotation. So we know, actively and passively, if that doesn't move, he will be able to forward flex to 90 degrees because it's the scapula that does all the movement. Not rocket science. Yeah? Which is exactly what's happening here. If you look, he's lifting his arm up. One side can get all the way up. He gets, what, 95 degrees on the affected side. So diagnosis is, going back to our list, what is the most likely diagnosis now out of those 3? Frozen shoulder. If you have an acute calcific tendinitis, generally you do lose a bit of ER, but not quite as much. You might lose about 50%. So what are we going to do? We want to confirm that we're not crazy. We want to send them for an investigation, perhaps, to confirm or refute. So what is the investigation of choice then? Because what else could this be, theoretically? We said active and passive external rotation. I appreciate that he said I'm not epileptic and I haven't been electrocuted, what have you. And he is a bit young, but the other things on that list are arthritis. So what does ultrasound tell you about the joint? The sum total of fuck all. Okay, it doesn't tell you anything. Simple test, you can do it there and then, and you can look it up. X-ray, okay? So send him for an X-ray, and then you get this. So effectively this X-ray is normal, all right? If they had a calcific tendinitis, which is definitely on that list, you could never, you never 100% all the time, but you would see a blob of calcium in his cuff. You go, hell, I've got the diagnosis, I know what I'm treating. If that calcium blob is not there and he's got a normal X-ray, hell, I know 100% what I'm treating, 100%. Then you can say, I'm going to start treating you, okay? So this person, we've decided, he's pretty young, but he's developed a frozen shoulder. He's not diabetic. Diabetes does increase your incidence of developing a frozen shoulder. Treatment options consist of what, guys? So first thing, Codman came out with, so to classify the natural history, so if you ever want to treat anything, you've got to know what the natural history of it is.
Depends on the state.
So the natural history described by Codman in 1930 in his book called The Shoulder said there are 3 phases, phase 1, phase 2, phase 3, or freezing, frozen, thawing. Phase 1, painful. He's got pain. I don't know about you guys, I don't like the idea of being in pain, particularly if you can't sleep and what have you, that's misery. So we want to get them out of pain. So the thing that is being shown to get them out of pain, and I only present, I'm telling you what is in the literature, which is, this is not stuff that I've made up. Steroids, corticosteroids intra-articularly, okay? That reduces pain, gets them out of their painful states and pushes them into phase 2. It does not change the longevity or the natural history of this syndrome. They're still going to have a frozen shoulder, but it ain't going to be painful. You could, again, literature, give them oral steroids. You could give them a pulse 5 days of 50 milligrams of prednisolone. Complication profile, slightly different. So we don't do that. We tend to put an injection into their shoulder. Okay. So that's what I would do if that was my shoulder. Please stick an injection or get somebody to stick an injection and get me out of pain. Yeah. Although there is some evidence for impingement, there was a paper about 5 or 6 years ago. They were randomising injection into arse of depot, ledrone, and subacromial injection, and they were both equally as effective. The bottom line is steroids help. Okay, get you out of pain for frozen shoulder. Then let's say we've got them out of pain. They're in phase 2. The world is your oyster. Next thing we're all here to do is we're here to advise our patients, primarily and foremost. You give them information. And I appreciate there are, varying sort of practitioners here. Again, I'm only presenting data that has been published on this. Physiotherapy alone, there are papers that say physiotherapy alone does help, but also doing nothing does help as well. Okay, so there isn't that much or any real evidence showing that physiotherapy actually helps to get rid of frozen shoulder in isolation. I'm sorry, some people got upset with me before when I said that, but it's the truth. Physiotherapy does help if you're doing it in conjunction with another treatment. And quite often patients you'll see, they'll say, oh, it's not, I'm having physiotherapy, I'm not getting better, actually my shoulder's painful, particularly midweek, because on Wednesday, you don't tell you this, but you get it out of them. You say, when's it worse? Oh, Wednesday, Thursday. By the weekend, I rest it. But they go and see their physio on Wednesday afternoon, or Wednesday, and they don't get any sleep that night. Okay. So you give them education, say, look, it's natural progression of this. It's very likely to get better by itself. It will take 18, 24 months in most people, but not everybody I saw my sister's friend recently, frozen shoulder, she's in phase 2. I told her everything that I'm just about to tell you. She said, oh, don't worry about it. Don't want anything done. I'm happy I've got my kids, it doesn't piss me off too much. Leave it alone. Fine, okay. Option number 2, do something. So if you're going to do something, physiotherapy does help in conjunction with either surgery or a hydrodilatation. Okay? In the good old days, and there are people on planet Earth, even in the UK, who are doing manipulations under anaesthetic. I did them when I was a trainee, I'm sure you did. It is amazing. So you put people to sleep, and when they're under general anaesthetic, okay, their arm obviously doesn't move any more than it did when they were awake, because this is a capsular restriction. You grab their arm, you try and grab it as proximally as possible, and I shit you not, because you don't want to break their arm. It does happen.
It does happen.
You've got to avoid breaking their arm, so no twisting it. Grab their arm, under general anaesthetic, you look at the anaesthetist and you go, are they deep? And they go, yeah, they're deep. And then they're lying down and you get them. And everybody, you look around in the room and there's like a few white faces and they're thinking, shit, something really bad has just happened. It's this mighty sort of tearing sound, okay? And then after that, their shoulder is more mobile because you've torn their capsule. There have been at least 2 studies, one by Lowe, I can't remember the primary one from the other one, randomised controlled trials looking at MUA versus arthroscopic release. The studies were stopped because of the fact the MUA arm revealed that they had chondral injuries, they had labral tears, cuff injuries, slap injuries, all sorts of things. Because there's not a lot of finesse in it, let's face it.
And all the other structures are going to break before you get fibrosed.
Or something. That's why sometimes the humerus breaks. So if you've had a frozen shoulder for a long, long time, you actually get osteopenia. You lose muscle, bone mass in the humerus. You can break it. So anyway, we don't do that anymore. So you'll be pleased to hear, but there are people who do. People do do it. People do it. There's actually a national trial. Anyway, we're going to do it. Yeah. So options, hydrodilatation. I give the options to the patient. You can go and have an injection into your shoulder. I get a radiologist to do it. Put the needle into your shoulder under ultrasound. We push 40 mils of normal saline, local anaesthetic. We stretch the inside of it, and we put a little bit of steroid in local as well. And then they go off immediately to see a physiotherapist or a chiro or somebody to continue some active and active-assisted passive range of motion exercises. The rationale is that, you know, you go to a party, you've got to blow up a whole load of balloons. At the beginning, blowing that balloon up is difficult, but once you stretch it, you're actually able to make some gains. So if you have a hydrodilatation, you must see them the same day, okay? Or an arthroscopic release, great operation, but it's surgery. It's either general anaesthetic or regional block, day surgery, little cut the front and the back, and you go into the shoulder. MRIs of shoulder, sorry, I put this in. Somebody with an MRI of a frozen shoulder is likely to be reported as normal, because it is pretty normal, all right? Put shit in, get shit out. If you don't tell the radiologist there's frozen shoulder here, perhaps as differential, you really shouldn't be sending them for an MRI, to be honest. It looks normal. The only subtle differential, there's a little bit of increased signal in the inferior capsule. That's it. So MRI is not helpful. Ultrasound, not helpful, because the shoulder doesn't move. For you to see the cuff, you've got to be able to actually move your shoulder around. That's why ultrasound's helpful. It's dynamic. If you've got a shoulder that doesn't move, you can't see anything, okay? And the arthroscopic release, if you put the camera inside, it's all red and angry, but then you just get a pair of scissors and you snip down the capsule, okay? It takes 20 minutes, half an hour, and at the end of the operation, you take them to the recovery room. You've got regional blocks most of the time, hopefully, so the shoulder's nice and comfortable, and then you go, look at your shoulder, which hasn't moved anywhere for however long. They go, oh, look at this. They go, wow. And then you say, look, if it doesn't work now, it's your fault. But it's really quite a satisfying thing to do, but I don't do it in everybody, and I must admit, if I have a frozen shoulder, it's not where I would start. But it's a reasonable thing to offer. So I do give, and Adrian does say, you give the patient the information. And this guy, I don't know how long his shoulder was frozen for, 2 weeks out, he's still got stitches in his shoulder, he's got his range back, he's very happy.
Yeah,
It's not a perfect world. I'd probably send more people for hydros than you, maybe. Or, it's all about, we're all here to give the patient information. And there are a whole load of other cases and stuff that we run out to.
Thank you.